So welcome to this episode talking about bridging the divide, how virtual education is shaping the future of nursing. We are joined by Mikhail Shneyder, who is the founder and chief executive officer of Nightingale Education Group, a mission-driven organization focused on innovative nursing workforce development across its entire professional continuum, from pre-licensure academic programs to graduate studies to reskilling and upskilling through continuing education. Shneyder serves as the first president of Nightingale College, a higher learning institution dedicated to closing education equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession throughout the United States. A registered nurse for more than 25 years, Shneyder has a wealth of management experience in post-secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer specializing in strategic planning, organization development, forecasting, and management.
Welcome, Mikhail. It's so great to have you here with us today. My name is Krista Natoli. I am CTeL's Executive Director, and you just heard from Lydia Homovich, CTeL's Policy Analyst. Welcome, Mikhail.
Thank you so much. Thank you for having me on the Telehealth Policy Scoop podcast. How exciting.
You're our
I'm
first, so no pressure.
fantastic. Well, let's do this. Let's chat up a storm.
So we are going to talk all things nursing and digital health today in VR. And it's something that's really close to you and the mission at Nightingale. So, thinking about nursing and the huge role that nursing plays in improving access to care to patients all across the country, and then the overlay of in trying to improve nurse education in a way that keeps up with technology. I wanted to know, do you think we could have a little bit of a conversation about, the need to address these policy limitations? It almost seems like, the technology and the environment for education is light years ahead of where the policy lands. And how is that impacting
Yeah,
you right now?
that's look, a great question. And I want to start with this. One of my most favorite quotes of all time come from Dr. Deming.
Mhm,
Back decades and decades and decades ago, he said something to the extent of every system is perfectly designed to
mhm,
produce precisely the outcomes that it is producing. And so if you dig into or essentially look at the system outcomes in our healthcare
mhm,
system overall, nursing, professional system, and so forth. You see, I mean, we know it.
mhm,
Much is to be desired here, right, in the outcomes. The estimated shortage of nurses right now, according to McKinsey, as of today, and it's a
mhm,
conservative estimate, but at about 250,000 RNs are missing from the workplace, right? And with that, US spends the most on healthcare. We get the worst outcomes from our comparative group, Western Europe mostly. And again, our health equity issues exist throughout. There is quite a bit of difference between access to care, depending on where one lives, and it goes on and on and on and on and on. And we always try looking very close to the issue
mhm,
itself, to the outcome itself, to figure out, well, what can we do? What can we do better at that point of impact in order to improve the outcomes? And what Deming suggests is that we have to start looking all the way upstream in the system in order to get to exploring solutions that actually may make a difference downstream. And you're right, regulation and how the regulatory system specifically around nursing education is set up plays a huge role in driving these less than desired outcomes downstream. So, and yeah, we get to talk about this today, but I'm excited to be able to dig into it and look into it. And you're right, solutions are there, solutions are available.
Mhm,
They are largely prevented from implementation
mhm.
because of how the regulation is structured.
And I want to highlight a statistic that you started out with. You're saying that we don't have enough nurses, but some
Correct.
data suggests that we might be in a shortage, but it's just a geographic shortage. What are your thoughts about that?
Look, we love averages, right? And we look at averages all the time. And I can tell you this much: even if a state in this nation, on
Yeah,
average, looks like the supply maybe is there and the
yeah,
RN per capita,
yeah,
maybe the highest, you
right.
still will have pockets, geographical pockets in that state where absolute shortage exists. And another thing too, we haven't look, every state comes out and says, "Look, we have licensees, right? And supposedly we're not as short as maybe with California. There's some rhetoric like that in the state, which we know experiences quite a bit of shortage if you look at the work, openings and so forth. However, what California does, along with many other states, count all of the licensees within their system. Now, these licensees include people who actually live in California. These
Mhm.
licensees include people who used to live in California and maintain their license there, but no longer practice there. The number includes also all of the travelers who have traveled to California to help meet the workforce demand, and then for a few months or a few weeks, and then they move back. So all of these numbers, state-based numbers, are hugely hyperinflated. And so again, what the better thing to look at is the
Mhm,
BLS, right?
mhm.
And the data on actual job openings, which are tremendous. And that's what McKinsey number that I quoted goes by.
So that brings up an important point. If we are trying to use technology like digital care to bridge that gap between patient and provider and rely on
Yep.
nurses to be able to do that in a digital environment, is that possible if we just don't have enough nurses at bedside?
So absolutely, look, technology will come in really hot and plays an important role in the solution,
Mhm,
right? And now with the advancements in AI and agentic AI and ambient listening and transcribing and all of the things that are already possible, it certainly will expand the capacity of a bedside nurse to deliver care, right?
mhm,
And maybe focus on the human skills and human part of it. Telehealth certainly plays a huge role across the country in order to be able to fill this gap. However, we're still in the need of more practitioners, and same or similar
mhm,
to utilization of technology in healthcare, we can utilize technology quite effectively in education to
mhm,
produce more nurses, to create this readily available, relevantly skilled workforce, nursing workforce, specifically representatives of the communities that it serves, which is at the core of the mission at what we do at Nightingale. However, despite the existence of these solutions, obviously, as you know, on a telehealth side, and
yeah,
as I'm very familiar on the nursing education side, regulatory barriers
mhm.
play a significant role in continued non-proliferation of these solutions that really we need in order to improve health.
So I think that's a great segue, Mikhail. To recap, it sounds like we are not only in a geographic shortage, we're in a nursing shortage overall.
Correct.
And so that's problematic, because if you have a hospital that has need for nurses at bedside, they're not going to be able to be pulled off the floor and be used for digital health solutions. So there's a link there. I mean, this shortage is
Correct.
going to ultimately impact digital health providers and digital health solutions that are created to bridge these healthcare divides. So it sounds like in order to fix this, we have to fix some policy and regulation. But we also have to figure out how we can get more nurses through nursing school. So the next question I have for you is what's holding nurses back from going to nursing school? Are they not interested, or is it
Uh,
just have interest? Or help me understand how we can get more nurses interested in going to these classes.
Absolutely. So, and I want to kind of circle back just a little bit to what you said before. In a hospital, the more rural a hospital gets,
Yeah,
the more pronounced this is,
right.
which then brings me to the answer to your question, is that, look, we have no shortage of people in communities throughout the United States
Mhm.
who are interested in becoming a nurse.
Right.
However, its access to education is
Mhm.
that they do not have within their community. And
Yeah.
this problem has existed for rural communities, specifically in the United States, for a very long time because of how traditional education is concentrated in urban centers. And
Mhm.
so, if somebody in a rural community has interest in going to school and they then can actually afford to
Mhm.
go and live somewhere else and go to school somewhere else, they do that. However, that doesn't help their community because, uh, literature says they very rarely move back into their community and work in the community and support their community. And so, in order to truly the solution to work, we have to figure out, which we have,
Mhm.
how to bring this education to anyone who is interested in it. And another, the flip side of it, look, the nursing itself is an incredibly the job. Look, I'm a nurse, right? And I haven't been at a bedside for 20 years now, but even back when I was practicing bedside, it is a tough job. It is a tough job, and it takes a lot out of a person, and you have to be so passionate about care, and so dedicated and so resilient, really, to be able to do this job that uh, and so it takes a lot out of people. And we have on TV a lot of shows, for example, that touch upon nursing, right? It's all glamorized, it's all about McDreamies and which has nothing to do with the praxis itself. And so we've created, there was this interest that wasn't a profession,
Yeah.
kind of very sustained interest up until COVID.
Mhm.
And then people actually saw the sort of the both the stress of it, the what
Yeah.
it takes. The media was obviously all over during COVID about it. We know how tough it was for the nursing as a profession to get through it. And then obviously some nurses said no more. And I cannot do this any longer. I am leaving. And then it also put a damper on this interest up front in the
Mhm.
profession as well. So we have to, yes, we have to get more people interested. Literature says, look, you have to get to kids when they're between sixth and eighth grade to go and plant that seed and show that nursing is absolutely, for boys, for example, it is a heroic profession, right? So
Mhm.
let's show this that superheroes are there in nursing as well, and you can become one. But at the end of the day, after the interest is generated, after the interest is there, we have to figure out both how to solve the financing issue of it and the regulatory issue of it to make it actually accessible and available to people who want to do it
Mhm.
at the where they live, essentially in their community.
Yeah, and you bring up a great point. Education is really coded in elitism. So, not everyone has the same starting point. And
Exactly.
you graduate from high school and you want to do something next with your life, and you're thinking about trade school, you're thinking about a professional degree, and you might not be able to just live off of student loans, or you might have children already at that point. You need a program that's going to allow you to have a bit of flexibility. And
Absolutely.
some of the research indicates that the reason that nurses do not go into nursing programs is because of cost and time and
Yes.
flexibility. But I think we have to improve access to care to patient populations, but we also have to give them access to providers that understand cultural nuances within each of these individual communities.
Precisely, and again, nursing education, because of how the regulation around it is set up, has been reduced to somebody's ability to pass a test on the first attempt, not necessarily their resilience or their preparedness for praxis or their competence or anything else, or their cultural, sort of mirroring of the community that they would serve. But it is all about the test, right? Nursing, by the way, is the only licensed profession in the United States, in the vast majority of the states, which requires a large number of the graduates of nursing programs to pass the licensing exam, which is a standardized exam on the first attempt. And then it doesn't matter to these regulators that somebody may pass, 2 months later, and it's on their second attempt, and still become an excellent nurse that is culturally aware, that is really skilled, very resilient. And
Mhm,
yet these folks are actively kept away from
mhm,
entering the profession because of how regulation drives that outcome. So a lot, both in the financing of it and figuring out how to pay for it. By the way, let me just touch upon finance a little bit. So essentially, you know, every state in the union,
mhm,
except my home state of Utah, which defers the approval of nursing programs to actual accreditation. So
mhm.
programs, in order to be approved in the state, the programs must become accredited by
Right.
a recognized national accreditor of nursing education. And those folks understand nuance way better than regulatory boards, let me tell you that much. But anyway, so all of the other states have a gamut of different regulations and inputs that they're requiring. They say one may need 200 hours of X and 300 hours of Z, and so on and so forth, in order to become a competent nurse. Well, nothing can be further from the truth. We know so much about adult education nowadays, then we are certain, the science is certain on this, that one person can achieve a certain outcome in 2 hours, whereas somebody else it would take 20 hours. However,
Mhm,
both of them are as able to get to the outcome that's required. Now, we've created regulations that say, okay, you have to put X number of hours
mhm.
to get to pass the exam on a first
Right.
attempt, and that's the only thing that matters. And then the finance system that says, and if you clocked in the hours, we'll pay you for it, school, right? And good on you. And so whether the outcome that is needed, which is competent, confident, compassionate new practitioner out in the workforce, is achieved or not, the money flows. So
Mhm,
again, it does require these two upstream systems, finance system of nursing education, and the kind of the regulatory prescription like
mhm.
system must change in order for us to start experiencing different outcomes, to produce more providers who are culturally mirroring their communities, and who are resilient but may not be like the best standardized test taker in the world, right?
Mikhail, you bring up a great point. I'm from Northeast Ohio, and the city that I'm from in Northeast Ohio, most people fall below the socioeconomic poverty line, and nursing is the track, the professional track, to get out of
Oh
that
yeah.
that cycle of economic decline. And so many of my friends have gone from back home, have gone into nursing. Two of my friends were 2/3 of the way done and their nursing school just shut down.
Yeah.
And they have invested all this money and this resources. Some of them
Energy.
have even done their clinicals, and they had to start over. They had to find a new nursing school and start over. And let's talk a little bit about, like, why is that happening? And and especially in communities that need nurses, like the north part of Northeast Ohio that I'm from, huge clinical shortages. Hospitals are closing because they don't have enough healthcare providers. These
Yeah.
schools are shutting down out of nowhere.
Yeah. Um, Great point. Great point is that nursing it has been for a while now, and still to this day remains one of the best economic mobility vehicles
Mhm,
that we have in the nation. And it is able, somebody getting that education and receiving that license
mhm,
literally breaks intergenerational poverty cycles.
yeah,
However, the accessibility, again, is not there. Now, first of all, it's driven by regulation.
mhm,
So, say a board of nursing in
mhm,
Ohio says, 80% of your graduate nursing program, and I don't know what the precise Ohio regulation is, but something to that extent, must pass the licensing exam on the first attempt. So two things happen normally in schools adapting to such policies. A, they, in the first place, do not admit anybody who is not a great standardized test taker. So and those are the folks that come from communities that live in poverty or don't have access to resources, did not go to the best possible secondary school that may be there, right? And did not learn how to beat standardized tests. So excluded right away. However, some schools enroll them
mhm,
and then try to do a good job progressing them to graduation and so forth. But then they graduate these folks and they do not pass on the first attempt. They pass. Eventually, with persistent attempts, our data shows that everybody is able to pass. However, they don't. And then the board of nursing turns around and tells the school, you're doing a horrible, horrible job, and we're going to shut you down. So this is one of the mechanisms by which that happens. Another one, the schools that are more maybe not as mission driven as they may be, they tell then those folks that because we are afraid of being actioned against
mhm,
in not getting this standardized pass rate to a
mhm,
certain level, which is not going to let you graduate. So all of the time and all of the money and all of the energy that you've put in as an individual into it, and the taxpayers and the supporting you and whatever else is out of the window and goodbye. And so, and then they, the completion rates in nursing education specifically that serves lower income population is dismal. Is really dismal. We're celebrate when it's gets above 30% and
mhm,
with on already numbers that are very small in enrollment to
mhm,
begin with, and then the schools beat themselves in the chest and say, hey,
mhm.
look at us, 100% of them passed in the first attempt.
Yeah.
Well, but how much of the public good have we actually created through that? Right. So again, questioning, I started nursing education 20 years ago, and I came into it as an outsider after being a
Mhm.
nurse bedside and then managing services. And as soon as I started in education, as we talked about before, none of it made sense to me. I
Yeah.
started questioning absolutely all of it and saying, well, why? Well, like, why does somebody need to pass on a first attempt? Like, what's in it? And the answers that I was getting from boards of nursing at the time were like, well, it's in the interest of public protection, which is such a cop-out answer. Like it's not, there's no science behind that answer, right? Or well, we've done it this way, it's a good thing, and so we're going to continue doing it this way. And I, but a little personal here, I'm going to get
Yeah.
just tiny bit personal, is that I did not pass NCLEX on the first attempt. I did
Yeah.
not. English is my second language. I came into the country as a refugee.
Mhm,
And so I passed 30 days later. But
mhm,
according to most of the boards of nursing
Mhm.
that are here in this country, they would say that my nursing school has done an absolutely horrible job in preparing me for practice and then things. Look at me now. I mean, I'm not suffering right, from the fact that I did not pass on the first attempt, nor did my patients, nor did my employers, and so on. And so again, the ridiculousness of some of these things that exist within nursing education regulation is, and the fact that there's so many variations of these requirements that by definition, if different people consider different things to be good, none of it is, and none of it is science-based. And so moving away from that would allow us to get more people into the profession, and again, more folks that could use this as a vehicle to break through the poverty and contribute better and make it better for our economy.
Mhm.
Yeah, so let's.
You bring up a really great point, Mikhail, because and let me just summarize for our listeners that might not be aware of the hold that nursing boards actually have over the NCLEX, which is the NCLEX is essentially the board exams for nurses to
Yeah,
show that they have competency. The NCLEX are administered by the National Council of State Boards of Nursing. We've talked to NCSBN, and they have said that if a nurse passes on the first time or 100th time, as long as they pass, they're considered competent to work in the field.
correct.
But because this is not federalized and this is a state-based issue, and
Yep,
licensure boards are regulated at the state level, nurse licensure boards could create policy that says you have to have a 70, 80, 90% pass rate, or else your school will be paused or shut down. And that
yep,
means that anybody that is within that funnel to graduate will the school, I mean, their academic career at that university is over. And a lot of times other nursing schools will not accept those credits.
correct,
And
correct.
this is unique because, as you know, we work with at CTeL, we work with all licensure groups.
Yep.
Doctors don't have this issue,
Nope, nope,
attorneys don't have this issue,
nope.
TAs don't, uh,
No, physical therapists don't have that
physical
issue. I mean,
therapists don't.
nobody else has this.
And, they are all providing care to the public, and there are safety concerns across the board. If somebody was, wouldn't there be safety concerns if one of these healthcare providers or professional licensee holders didn't pass on the first time? But that's not the case.
Correct, correct. And the exam itself, right, is designed as the pathway into practice, as the barrier to pathway to practice. And so, by definition, if somebody's passing it on the second attempt or the third attempt, and you're saying they're less than those who have passed on the first attempt, shouldn't we question the exam then
Right.
itself,
What's the
right? Because
relevancy of this
it,
exam if
exactly, if that's the argument, but that argument is being used as well, and you're pointing out precisely correctly that nursing is the only profession that has this. And again, the fact that we're experiencing the shortages that we're experiencing, and sort of continued non-diversification
right?
of the profession, are due to in part to these policies, and the fact that there is not a national policy and a national standards uh,
Mhm.
uh, it around this. And also, another thing that is very unique to nursing on the state regulation and policy side is that all of the other licensed professions, all of them, defer the approval of the educational programs to the accreditors. Nursing is the only one that says this handful of people that work at the state board somehow know better than hundreds and hundreds and hundreds of actual education professionals that are come from diverse backgrounds and contribute to creating accreditation standards. And so the again, unless that changes, right, hoping that we will start experiencing a better outcome in the supply of nurses or preparedness of nurses for actual practice, which employers constantly say new grads are not prepared to hit the floor running, so to speak, and that will never change. So we must drive these changes on a state level. And maybe federally, right? Maybe there's some kind of preemption thing that
Mhm.
federally can be done, so the at least we can start educating these folks in more numbers and preparing them better, and not just to pass standardized tests, but actually to practice and be effective in it. So yeah.
CTeL had a meeting with the secretary's office at HHS in June, and we brought up this issue of this nursing shortage, this clinical workforce shortage being a public health
Yeah,
emergency, and that if you have arbitrary and bureaucratic policies that truly are not backed in research, and it's
correct.
impacting patients' access to care, this is truly create this, along with many other reasons, is contributing to this public health emergency if we just do not have enough providers with
Yeah,
we don't have enough providers at bedside for these patients. And that poses a risk. There's data upon data that shows that nurses are being overloaded with patients. When you have that, there's potential
yeah,
for mistakes. There's burnout, not to mention the impact that it actually has on the healthcare provider. They're more likely
correct.
to be stressed and go through depression and turn to substance use. And even they themselves could potentially become addicted to different substances and have a substance
Yeah,
use disorder. And so this is creating this systemic problem. And it sounds like the pathway, we have people that want to be nurses, and
absolutely,
we have people that want to be nurses and stay in their community.
absolutely.
But we have these arbitrary laws and regulations that originate with the nurse licensure boards about first-time pass rates that are impacting the nurses that can actually get into the field. Because if you shut down a school, you're shutting down maybe 600 nurses that were
Correct.
going to go into that field.
Potentially.
Yeah.
Potentially, yeah, and you're right. So accessibility is the issue, right? The again, by design of the traditional design of nursing education, it's not available everywhere. It's not available readily. It's not available to everyone who may possibly want to go into the profession and use it as a economic mobility vehicle. And so, good news though is that look, I knew that this could be different back when I first started 20 years ago. And
Mhm.
then, I was lucky enough that a very sort of mindful investor, some 13 years, 15 years ago, said, "Hey, let's maybe try creating something that would solve these issues, that would solve the geographic access issue first and foremost, and then start solving for other things within it." And we were able to build it. But the only reason we're able to do what we do is because look, from the nursing policy standpoint, I live in the most progressive state that there is from the policy viewpoint, that allows for innovation to be, and it has allowed us. So Utah essentially has allowed us to build this nursing education delivery model that is fully distributed and fully distanced,
Mhm.
and bring it to any community in the United States through some other regulatory mechanisms that exist, like National Council of State Authorization Reciprocity Agreements. And so we're able to do it, right? The precedent is there.
Mhm.
It's just way more providers outside of Nightingale really have to get involved and be allowed essentially to deliver this education for us to start solving these like huge systemic problems that we have. And one more thing that I'll throw into it, back to this counting the hours,
Mhm.
right? It shouldn't be about our education should not be about hours counting at all. It
Mhm.
should be about preparing somebody for something, right? Preparing them for a career and whatever it may be, for a job that they would take. And
Mhm.
and again, because adults all come from different places with different background, different knowledge and
Mhm.
different experiences and competencies that they already have, it takes different amount of time
Mhm.
for one versus another to arrive to the same competency level, but it is absolutely possible. And what we need to be focusing is on actually developing these competencies, which is
Mhm.
what competency-based education is all about, and not counting the hours
Mhm.
one way or the other. And so, but again, in nursing, we're probably because there's so much resistance to even considering that we may focus on competency based rather than just telling somebody just do 200 hours of this and you'll be fine. Well, that's not true, right? And so until that starts again evolving and there's enough advocacy and there is enough awareness, I think, in the public and
Mhm.
and then government and legislatures. I speak with legislators in different states, and they're absolutely oblivious to
Mhm.
what is happening and why it's happening. All they know is that, oh my goodness, there's a nursing shortage, and we have tried everything there is to try. And to which I always say, no, you haven't. And so there are solutions, and they do exist.
We, Nightingale and CTeL went to that meeting together at HHS,
Yes.
that with the secretary's team, and we'll be meeting in September to with a small group to talk about what next steps are for the public health emergency and what that will do.
Yeah.
Um, improving those nurses that could be in the field improves access to care. But, there's also, you talked a bit about education, and there are a lot of these nurses that are going to stay within their communities have barriers, transportation barriers or time barriers, and there are some clinical requirements, but that is being made easier because of VR and virtual reality technology.
Correct.
Talk to me a little bit about what that is, because when I'm looking at virtual reality, it's usually the clinician that's using virtual reality to care for the patient. And it's new to them. They've never used telehealth before until they
Yeah.
started practicing, or they never used VR, or they never used robotics intervention. But Nightingale is actually making that part of their learning program. Is that right?
Yeah, absolutely. It's an important part of the program. And look, simulation has been around for decades, really,
Mhm.
right? Since about 1960s, it's been available, and the way it was done prior to that, and it is. It essentially is designed to increase engagement with a with clinical situations and so forth, to develop reasoning and hone kind of resilience and
Mhm.
communication skills and so forth in an environment that is safe and
Mhm.
controlled. And
Mhm.
so and we've again, the modality has been around. Look, aviation has been using simulation since the dawn of like learning about, because you wouldn't put somebody in a plane right away for them to go,
Yeah.
go wild at it, right? In commercial aviation, they go through hundreds and hundreds and hundreds of hours of simulation before anything else happens. And this is the vast majority of how they learn. Of education is done in simulators. So, and in medical and nursing education, back to 1960s, it really started as medical, and then probably about 20 years ago, so nursing finally caught up to that we could use these big, expensive physical simulators to,
Mhm.
and the way it works is that a group of students stands around while
Mhm.
one of them engages in some interaction with a mannequin that is voiced by a faculty from, behind the wall. and all of this. And it's like cool. Like if there is nothing
Yeah.
else is available, and that's the best that's available to increase this engagement,
Yeah.
great. But we have, virtual does it way better. And I'm going to set this aside just a little bit to talk about the clinical. So a lot of these hour requirements that I'm talking about are in clinical facilities. Now, and it's well known that there is some perceived, it's not as real as some people may say, but perceived lack of clinical placements and so forth out there. So simulation could potentially solve for that. Now, but it's when somebody is prescribing
Mhm.
200 hours of, say, med surge,
Mhm.
nursing, clinical hours in order to complete a nursing program and prepare for practice. What they're not thinking about is that those 200 hours that are spent in a clinical, very little proportionately is spent in actual engagement in something or in actual learning, because a lot of it is waiting around, same as standing around a mannequin. It is waiting around for your turn. It is hoping that something is going to happen, and
Right.
then some patient situation, right? And then when the most acute and the situations where learning can be so rich actually happen in clinical environments, students are not allowed to be anywhere near it, right? Because you wouldn't give a student somebody's life in their hands and say,
Yeah.
"Hey, here you go see what happens, like practice." And
Let's hope
so,
not.
and again, right.
Yeah.
So it's preposterous, and the effectiveness of clinical, like actual clocking in hours and clinical rotations, it is not an effective way to learn. Virtual reality solves for all of those things. It's
Mhm.
individualized,
Mhm.
meaning at Nightingale, every single learner receives an Oculus goggles
Mhm.
when they first enroll in their first, nursing course that has a clinical component to it. And they're able to engage in hours and hours and hours, 15, 20 minutes at a time, of different scenarios that are becoming increasingly complex as
Mhm.
they go through the program, and
Mhm.
practice and try things for size and make mistakes and
Mhm.
make errors and learn from that. As a matter of fact, when some learners, when they checked off and they've passed the
Yeah.
assignment, they go back into these simulations and start making errors on purpose to see what happens, right? And
Mhm.
then to try figuring out, okay, but what if I didn't do this? What would
Yeah.
have happened? And then the scenario itself, which is AI supported,
Mhm.
takes them on a wild ride. And so which learning happens over and over and over again. And it's this learning happens with engagement, learning happens with practice, learning happens with that. It doesn't happen from somebody reading a book or observing something, standing and observing something. You have to actually engage. This is how human adult brain learns. We
Right.
have to create neural pathways, but the only way to do that is by actual engagement in learning. And again, virtual reality, which is AI supported and based, is a great place to develop clinical reasoning, a great place to develop communication skills, a great place to to try something and fail and
Mhm.
still not harm anybody. So look, I cannot say enough about this modality, and yet again, when we talk about regulation, regulators are scared of it, scared. Although we're publishing data, other folks are publishing data on this, that it is way more effective than anything else as far as learning efficacy is concerned. It is more effective than other methodologies of learning to develop competencies on clinical reasoning. And again, and all of that science is being pushed away because of somebody's just fear, or a simple, new and scary, and we've never done it, and so we're not going to do it. And as a matter of fact, we're going to put additional barriers in play that prevent this technology from being used, and then again, hence prevent the opportunities for access to education and all of the things downstream that we've already talked about. So which way we're going to go, that's the question. And how I'm so thankful for CTeL driving the conversations with the secretary and otherwise and about this, right? That is it is so needed. Everything that I said this, I had a presentation at Meta, a keynote just a few months ago, and I said this: look, headsets are there, right? Meta like
Yeah.
produces the headsets.
Yeah.
Headsets are there.
Mhm.
Technology is there, and readily available headsets. What we need to change is mindsets. Mindsets have to shift in order for us to get to an outcome that is way better than what we're experiencing today on a systemic level. So, and VR is definitely part of that puzzle.
Yeah, I mean, if I were to talk to regulators, and we will be very soon in September, we had probably a lot more plane crashes in the early days of the Wright brothers before they were able to use
Right.
airplane simulations, right? And
Yes.
you just had to kind of learn, build your wings on the way up or down, depending on which way you went.
Exactly.
And
Yes.
there wasn't that safety net of being able to
No.
learn in like a very, very safe environment. And you know, if the military and NASA, if simulations are good enough for these types of very precise
Precisely. And if Sully
um,
can learn in a simulator and
yeah.
then land the plane on the Hudson, because he's experienced that in a simulated environment, I, it, what else can we say? But it's not. He didn't observe it from afar. He was
Mhm.
engaged in it himself, like, and every pilot engages in it themselves. And so you're right, NASA, military. I mean,
Navy fighter pilots are
right. What is
are
nursing waiting for, right? What are we waiting for, really?
and the other piece to this too is that nurses, doctors, just like those that are in the military or defense that were trained on medical simulation or
Yeah,
trained on simulation, nurses and doctors are not trained on it, but they're going to have to implement it into
correct.
their care routines and their protocols for their patients. And
Yes,
speaking from experience and talking to these clinicians, they say it's very, very difficult if they did not get an educational backing on how to use
exposure. Yeah,
telehealth or how to use simulation. All of this is, brand new. And so that's one of the pieces that CTEL is really proud to advocate for is that if we are asking clinicians to use digital health and streamline it into their into how they are caring for patients,
access. Yeah,
then we need to be able to train them on this technology if we want them to essentially hit the ground running on their first day at clinicals or residency. They need to be able to be trained on this, and it needs to be part of the
precisely.
curriculum.
Precisely, and not afraid of it. Look,
Yeah.
AI is here. The sort of the devices that every single healthcare practitioner, I am convinced, will wear on their face. They look like glasses. They
Yeah.
have the right lenses in them, but they also do many other things and sort of expand your capacity to not to make errors and so forth. Right.
Right.
But you're right, exposure to that within your education is absolutely necessary for somebody to go like, yeah, I'm familiar with this. Great, I'm going to do it. And literally, we have millions in nursing that we will have to slowly do implement like change management
Right.
techniques and whatever to get to this place of where it is commonplace and not just a thing of sci-fi, like the future is here, right?
Right.
Whatever's been described, and it's not as scary as sci-fi makes it out to be, right? No overlords and
No, and
skynets.
there is a disconnect between what is actually being done in practice and when general population learns about it. Telehealth's been
Right.
around since the 60s, same with
Yeah.
simulation, both in medical and in other fields.
Yeah.
this is already being used and done. AI has been around a lot longer than ChatGPT, and it's been
Yes.
a long time, even in healthcare. I was working on this 20 years ago when I started in digital health. And so it's progressed and it's changed, and it's gotten way, way better, and it will continue to do that. And so one of the things that we are trying to look forward to as an organization at CTeL is we don't want to encourage legislation or policy that will prevent technology that we haven't even thought of yet.
Oh,
We want to
absolutely.
access to patient, we want to improve access to patient care, quality patient care. We want to improve the workforce because all statistics across the board show us in a significant shortage in by 2037. People are
Yep.
going to be retiring, leaving the field on purpose, or just simply not being able to get into these academic programs, and the funnel is going to start getting depleted. So what is your, if you could wave your magic wand, what is your biggest policy request at the state level and then also within the Trump administration? What is your ask?
The wish list. Great question. Look, I think, first of all, getting to sound policy and then standard in a standard type of way, right, across the many different states on the education side is and on the digital health side and so forth. It's absolutely necessary. So
Mhm,
standardization is a must, and whatever policy changes are done, they have to be driven by actual science
mhm,
in education.
mhm,
It has to become competency based and compensating for competency based results rather than clocking in hours and then counting the hours and then being paid for those hours. Really, it's a much more mindful. We have to finally decide what is important. Is it important that somebody passes a standardized test on the first attempt, or is it important that they, following their education and following graduation, they get to the profession that they were trained for, whether it's on the first attempt or some subsequent one. But when they arrive in their practice setting, that they're ready to go, right? And it requires maybe 2 4 weeks of orientation or more rather than 1 year residency and so forth. So I really probably the outcome that would be, so certainly eliminating first time pass rates. Like that policy is insane and needs to go away. And there's all sorts of data. We will publish a paper soon here with even more on what kind of harm those policies do to the population that we purport to serve in the States. And then so that has to go away. And yes, and sort of counting the inputs rather than focusing on the outcomes of something, that has to change, and standardizing it across. So those would be my wishes, in nursing education specifically, and which will allow then more people to become more innovative on the provider side and do something that actually solves the actual needs of the
mhm,
populations that we're
mhm.
responsible for. Yeah.
Yeah, absolutely. And we are going to be hosting, as you know, Mikhail, but some of our listeners might not know that on September 23rd, we're going to be hosting an AI digital health tech showcase on Capitol Hill at the request of Congress.
Fantastic.
Take place in the Rayburn Foyer, on Capitol Hill. And the goal of this is to be a little bit preemptive because Congress is going to be, needing to vote on telehealth and digital health policies that are going to be expiring on September 30th. And that is going to
Yeah.
have an impact on patients receive care. And so
Care.
we want to show that uh, VR, telehealth, AI, simulation, all of this is being used to improve access to quality care for patients. And if some of these funding mechanisms go away or reimbursement goes away for digital health services, this will have a really negative impact on patients and specifically their constituents in both
Yeah.
rural and urban environments. So for those of you that are new to CTeL but are interested in joining us, please come on September 23rd. It'll take place in the early morning to afternoon on Capitol Hill in Washington, D.C. You'll hopefully see our friends from Nightingale there show off their VR technology, and
Yes.
so many others that are really looking to advance in digital health, but specifically advance policy to make sure that, regardless of where you're physically located, you could become and work in the field that you would like to work in. And you're also going to be able to help patients that are in your community receive access to good quality of care, which will ultimately decrease medical catastrophics and
Yes.
the whole healthcare system entirely, which right now is not doing so well.
Yeah.
And so we
And
need,
will be great for our economy
yeah,
altogether, right? Healthier population. There
100%.
is a lot to be said for that. Look, I applaud like everything that you do at CTeL. Yay, September 23rd. And we met some time ago, but from the first moment, your passion around this is palpable. Like, oh, meeting another person that is so invested into creating real solutions and changing things and improving health and driving that forward. So thank you so much. Thanks so much for this conversation. Thanks for having me and on your very first episode. And I love it. I'd love to come back at some point and chat again.
Oh, yeah, your wish is our command. We will absolutely have you back. Thank you, Mikhail. Thank you to Nightingale for changing how healthcare is learned and delivered to patients, and improving those that are wanting to become nurses being able to complete their education. And we will see all of you hopefully on September 23rd in Washington, D.C. at the Rayburn Foyer to join us for the AI Digital Tech Showcase. Take care and good seeing you.
Fantastic. Thank you so much.
Bye-bye.
Bye.